So I would like to thank Ferdinando for the kind invitation. I'm honored to share the panel with such an outstanding faculty. Thanks Mini Invasive Surgery and all the editorial office for organizing and coordinating this webinar. I'm going to talk about a controversial topic debated in the current literature, intraperitoneal mesh repair. Are we going to take the mesh out of the peritoneal cavity? So before going through it, as hernia surgeons, we are struggling to speak the same language and don't make the abdominal wall like a Tower of Babel. And this is the way we found the answer. A Delphi study was conducted involving 20 internationally recognized abdominal wall surgeons, and the initial list comprised almost 60 possible terms. So there was many terms to describe the same procedure. So this is the proper nomenclature that every hernia surgeon should adopt when dealing with mesh repair, describing new techniques, or filling the operative note records. So it is crucial to adopt this nomenclature. Hernia surgery is definitely a specialty that is rapidly evolving with new techniques and new technologies. And the first step and one of the milestones of the mini-invasive revolution in hernia surgery was published with this paper by Karl Blank in 1993. The laparoscopic intraperitoneal onlay mesh repair used to be the choice of mini-invasive repair for ventral hernias, aiming to reduce the invasiveness associated with traditional open procedures. Over the time, the IPOM technique has undergone evolution, and this is one of the major advancements of the technique by Kerala. So we have gone from IPOM to IPOM Plus, so from a bridge repair to a reconstruction of the abdominal wall, restoring the functionality and improving patient outcomes in terms of recurrence rate, bulging, and patient satisfaction. Sonia Ribas delivered an interesting talk on how trend of a surgical technique can be described by the Gartner hype cycle. So when the technique is introduced, we have the innovation trigger. Then we go towards the peak of expectation, and then down to the disillusionment until we reach a plateau. Basically, the mini-invasive, the advantages of the mini-invasive intraperitoneal mesh placement, like short learning curve, identification of other defects, lower rate of surgical site occurrence, shorter length of stay, and early recovery and improved quality of life, associated with no significant differences related to recurrence rate and acute and chronic pain compared to open approach, represented the winning formula of this technique and the reason behind its large adoption. There seems to be a divide between those who still advocate for IPOM repairs and those who rejected the technique. These two papers have been recently published and want to sum up those two sides of the barricade. Despite its conventional use, the IPOM approach has faded decline in popularity in recent years due to rare but severe complications such intestinal adhesions to the mesh and chronic pain associated with a traumatic mesh fixation. This paper by Kirkpatrick is an IPOM crusher. It starts with provides a comprehensive definition of the ideal mesh that should be non-toxic, of course, have sufficient mechanical strength and stable physical and chemical properties, ease of handling without displacement, anti-adhesive and anti-infective properties, and it should be, of course, cost-effective. To date, the ideal mesh does not exist. Major concerns have been raised over the performance of mesh within the peritoneal cavity and the potential for mesh-related catastrophic complications. Here we have complications of subsequent surgery, so that after re-laparotomy, 76% of patients with previous intraperitoneal mesh placement had perioperative complications compared with only 29% in patients with the preperitoneal mesh. And we have also to highlight that 21 patients required a small bowel in the intraperitoneal mesh group. Here we have also other issues related to mesh shrinkage, meshomas, and bowel obstructions. Meshoma related to intraperitoneal mesh are also associated with bowel entrapment, obstructions, enteroprostatic and enterocutaneous fistulae, chronic pain, any recurrence. So there is a huge issues related to the position of the mesh intraperitoneally. It is highly likely that intraperitoneal placement of mesh will increase the risk of adhesion formation and subsequent bowel obstruction, and should be taken into serious consideration when determining the mesh position. So we also have, of course, a higher risk of fistula creation that is facilitated by erosion of the mesh into the surrounding viscera. And the paper conclude that they believe that it's prudent to avoid the intraperitoneal placement of any prosthetic mesh until adequate and conclusive scientific studies have been completed. This paper by the high-volume hernia surgery group of Michael Rosen has been recently published on surgical endoscopy. They analyzed 325 patients with small to medium-sized ventral hernias with a follow-up of over 3 years. And they highlighted that one patient had early small bowel obstruction, but due not to intra-abdominal lesions unrelated to the mesh. 2 meshes were removed, one for chronic pain and one at the time of colon surgery for perforated cancer. And they had 16 reoperations, 5 for any recurrence, 9 for unrelated intra-abdominal pathology, 1 for obstructed port site hernia, and 1 for adhesive bowel obstruction, but unrelated to the mesh. Reoperation due to intraperitoneal mesh complication was lower than 1%, with up to 6 years of follow-up. Intraperitoneal mesh is commonly thought to stimulate significant intra-abdominal lesions, which raises concerns for future operations. This paper by Gray reported a 4-fold increased risk of reoperation with intraperitoneal mesh placement, but this report included mostly uncoated mesh in the intraperitoneal position. So basically meshes of the past. Clara assessed adhesions during reoperation of a large number of patients who underwent intraperitoneal repairs with a long follow-up of 78 months, and almost 90% were classified as Mueller 0 or 1, so adhesions free or having loose or mental adhesions only. Aiden reported no difference in adhesion formation or complication during reoperation based on mesh placement. And also data from Michael Rosen group is in line with these trials, demonstrating mesh-related complication at reoperation is rare. So this data suggests that IPOM ventral hernia repairs for small to medium-sized hernias should still be considered as a safe and durable approach. Here we have the recent guidelines from the European Hernia Society and the American Hernia Society that suggest to place the mesh in the peritoneal or retromuscular position. And so basically, they suggest when possible to avoid the intraperitoneal mesh position that may cause adhesions. So they advise for the adoption of extraperitoneal mesh placement. And here we have the suggested algorithm to repair of symptomatic umbilical and epigastric hernias. So we have, of course, the small to medium-sized hernias. We can go laparoscopic, but here we should go peritoneal or retroperitoneal or retromuscular plane, and so to avoid the intraperitoneal mesh placement. So where are we headed? Current expert guidelines favor extraperitoneal placement of mesh over intraperitoneal mesh, which has led to significant increase in the use of extraperitoneal mesh for several reasons, including minimizing mesh bowel interaction, avoidance of mesh fixation, use of non-coated mesh, so to lowering the cost, and improved ability to withstand mesh infections. Over the recent years, we observed a decrease in the incidence of laparoscopic intraperitoneal onlay mesh for hernia repairs, for ventral hernia repairs, from almost 34% to 21%, with the corresponding increase in retromuscular approaches from 32 to 41% between 2013 and 2019. But we also have some concerns here, because the large adoption of retromuscular approaches for smaller to medium-sized hernia can lead to posterior sheath disruption, linear semilunaris injury, and deep mesh infection. So, are current data, new techniques, and technology taking the mesh out of the peritoneal cavity, or should we have to reconsider the outcomes? Is it a matter of techniques or of devices? Are we overtreating our patients? Is it an overkill to go in the retromuscular plane for small to medium-sized hernias? So just like a bonsai live inside a tree, the answer lives inside of you. So we have to standardize the technique in order to better compare the outcomes. And we need more vigorous studies to provide evidence. Since the approval for hernia repair in the US in 2014, so 10 years ago, the rise of robotic platforms has facilitated the adoption of more technically advanced, minimally invasive procedures, allowing mesh placement outside the peritoneal cavity without the need for traumatic fixation. Here we are watching at a video that Konrad Belser shared with me some time ago, and here we can see on the left the robotic platform of Konrad Belser, and the hands of one of the master hernia surgeons worldwide, Yuri Nowitzki. And basically, the robotic platform is allowed for minimally invasive complex hernia cases. So another question that we frequently answer is, where is El Dorado? I mean, the ideal location for mesh is not a singular one-size-fits-all approach, and must be tailored to the clinical scenario. So every plane for mesh placement has benefits and consequences, which need to be weighed, suggesting a tailored approach based on hernia morphology, patient physiology, and risk profile. The drive to keep mesh out of the peritoneal cavity may have unintended consequences, including, as I was saying before, linear alba disruption, and Antonia provided us a complication of the posterior rectus sheath, linear semilunaris injury, and posterior sheath disruption, as I was saying. So the intraperitoneal mesh placement has been avoided for various reasons, but still remains one of the most well-studied repairs for small to medium-sized ventral hernias. So I would like to conclude with a quote by Cecil Wakely, the president of the Royal College of Surgeons in 1948. A surgeon can do more for the community by operating on hernia cases and seeing that his recurrence rate is low than he can by operating on cases of malignant disease. Thanks for this opportunity. Thank you so much to all the panel for this amazing event.